This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2020, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is, what would Dr. Tom think of COPD today? Dr. Barry J. Make is co-director, COPD program, as well as Director of Pulmonary Rehabilitation and Respiratory Care at National Jewish Health in Denver, Colorado. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability.
So the title of my talk is, Who's Tom Petty and What Would He Think About COPD Today? As you saw, he was a pioneer in COPD. And my talk really is going to be about a new diagnostic paradigm for COPD. And I'll try to walk you through how we developed this new paradigm. And you'll see in this slide some interesting things. You see gold. Everybody knows that symbol of the global obstructive lung disease, gold. Now, I don't know why they picked the name gold, but we're going to change that name for a new diagnostic paradigm to diamond. So think about that as we go through the slides, please. So these are my disclosures, and the first question will be, who is Dr. Petty? Rock star, Army doc, baseball pitcher, quarterback, fisherman. Now, you only have the opportunity to choose one. In 1 second, I'll get you to choose, and when the next slide comes up, please choose on your phone. Okay, your answers are Army doctor, fisherman, a little bit of all of those probably, right? Army doctor and fisherman. Well, I can tell you that Dr. Petty was an avid fisherman. A friend of mine in Denver, Dr. Jim Good, used to go fishing with him all the time on the Frying Pan, which is the name of a river in Colorado, and they go and fly fishing. So he loved fishing. And I'm not sure he was ever in the Army, but that is another Dr. Petty. These people's names were all Dr. Petty. So he was a doctor, an innovator, a researcher, a teacher, a leader, a writer, and a jokester. Now, I have to tell you about the jokester first. So, you know, there's a lot of conferences around the world. One of the ones in Denver that's popular every year is the Aspen Lung Conference, which Dr. Petty founded. It's now called the Petty Lung Conference, Aspen Lung Conference. And at the end of the meeting every day, we'd all go to the bar, right? And we would sit there, and Tom he had more jokes than anybody. He would sit and tell us jokes all night long. Now, this was even before he had drinks. So he was a great jokester. Everybody loved him for that. He was a physician, he was an innovator. You heard how he's an innovator. First pulmonary rehab program, oxygen therapy. You know, we use oxygen today because of Dr. Petty's study, which in 1980 said oxygen improves survival. So he did things that nobody did before. His innovation often got him in trouble. So my understanding is he did the first blood gas in the country. This machine's called a Van Slyke, and he had one in his lab. Got an arterial for a sample from a patient and ran it. And his attending physician said, "You did what? You can't do that. You can't puncture somebody's artery. We don't know about this machine and how it works. We don't know. You can't do this." He almost got thrown out of his residency at the University of Michigan for doing the first blood gas. But thanks to Tom, we do them. He was a great teacher, a leader, a writer, and a rock star. So the reason I put up that petty rock star is he did such a fantastic job and is known all over the world. He is in your Hall of Fame and he's a legend. So we really think of him as a rock star. And you see here the name of somebody else, Louise Nett, who was a respiratory therapist nurse. I think probably one of the first combined respiratory therapy nurses in the country. And that was Dr. Petty's companion in crime, both for pulmonary rehab and oxygen and everything else he did related to patients. So he has a long history of working with respiratory therapists. Some of the things I think that I personally think about, and I hope you will, is emulating some of Dr. Petty's best qualities. First, as a researcher, he was thinking outside the box. The blood gas, use of oxygen, pulmonary rehab, he developed new techniques. I'm going to show you something new today. It's not a technique, but it's new and different, and it represents some thinking outside the box. He was patient-centered, a caring clinician, and he was a great educator. You know, often you would have cases during grand rounds, and nobody knew the case, and you had to pick on somebody. Nobody ever picked on Tom because you always got the right answer. And he was an expert clinician. People would refer him patients from all over the world because of his diagnostic acumen, as well as care and management of patients. He had 153 publications on COPD. And he confided to me once, later in life, he said, I have a learning disability. And it is really, really difficult for me to write. I take days and days to write a couple of paragraphs, and yet 153 publications. So he overcame adversity as well. So I hope we will think about all that when we think about Tom. In terms of COPD, he looked at experimental emphysema and chronic bronchitis. So his definition of COPD was related to lung structure and pathology, emphysema, and symptoms chronic bronchitis. Now I'm going to be coming back to the theme of what is COPD. Tom thought of emphysema and chronic bronchitis, but later in life he became a strong advocate of spirometry, but he originally thought of COPD as emphysema and chronic bronchitis. Symptoms of cough and phlegm, and lung pathology, and we didn't have CT scans in those days. So this is the definition of COPD today, not tomorrow, but today. I'll show you what tomorrow's definition will be of COPD, and you all know this. So my question on the next couple of slides is going to be, is this satisfactory for your patients? Is it satisfactory for Dr. Petty, and is it satisfactory for you? Common preventable respiratory symptoms, airflow limitation, airway and alveolar abnormalities. So what do you think about this? The primary focus here, as you know and I'll show you later, is on airflow obstruction in a post-bronchodilator spirometry. So I'm going to ask this question. Where do you stand? There will be, as you can see, 5 answers. Definition of COPD is perfect. On the left, definitely A, E, no, and somewhere in between. I always offer an option of not being sure, so you see that C. It's okay, you can answer C. So your answers, please. I always like to see diversity of opinion. Probably not a good definition. Well, you looked at the name of my talk, so that's good. I like that. But the question is now, I want you to think as you go through this, why you think it's not a good definition in your own minds, and see whether we come up with similar answers or different answers as I go through the talk. So thank you very much for those answers. Probably a good definition. It stood the test of time. It's been around for a long time, and we have a lot of literature on it, so there's nothing wrong with that either. Okay? There's no answer to these questions. They're all opinions. So our learning objectives will be to define gold, strategy, definition of COPD. We talked about that. We're going to go through a story that will talk about respiratory abnormalities in people who do not have COPD by spirometry. And those would be patients who have normal spirometry and something we call Prism, which is preserved ratio impaired spirometry, and I'll define that. And then explain our new Diamond COPD Gene 2019 definition of COPD. So I'm going to present a case, and I think this case will resonate. Most of you have probably work in hospitals, have probably seen this patient. If you work in outpatient settings, you've probably seen the patient come in as an outpatient as well. So this is Tina. a 54-year-old woman who's admitted to the hospital with a shortness of breath, cough, and phlegm for the past 4 days. She can't catch her breath, walking up 4 steps into her house. She has yellow phlegm, her cough keeps her awake at night. You go back and ask some other history. She has chest colds once a year or so, and she doesn't get treated for it. She doesn't see a doctor. They seem to get better. She wakes up in the morning most days with cough and phlegm. Aha, that's Dr. Petty's chronic bronchitis. She has no history of asthma or other lung problems that have ever been diagnosed that she knows about. She is a current cigarette smoker. Long history of smoking, started at age 16, 38 pack years. And she's a little sick, as you see from her vital signs here. Her respiratory rate's 25, heart rate's 100, blood pressure's elevated a little, and she has no history of hypertension in the past. Oxygen saturation's a little low, and she's wheezing. She has no crackles, gallops, or edema. And you get some more information. She's got a blood gas that's consistent with her high respiratory rate and her oxygen saturation and her pulse ox. EKG is normal, and echo shows normal left ventricular function. Chest CT scan they get because they want to make sure she doesn't have a pulmonary embolus and she has no pneumonia, but she has some emphysema and airway thickening. Dr. Petty's emphysema. She's treated for a COPD exacerbation with the usual medications and drugs, and she gets better. She responds to treatment, and she's discharged to see her doctor within the next week. So 1 month later, she sees her doctor, and this is her spirometry. So I'm not going to ask this as an audience response question, but what do you think about the spirometry? What's your interpretation? FE1, FEC, 0.71, no airflow obstruction. FEV1 is mildly reduced. It's under 80% predicted, and she has no bronchodilator response. It's interpreted officially as normal spirometry. So now think about this. There's a patient who came in the hospital, they treated her for COPD, and by the current definition, she doesn't have COPD. Dr. Petty would say she's got emphysema and chronic bronchitis, she's got something. So we talk about underdiagnosis. Is this underdiagnosis? So does Tina have COPD? I'm going to ask you the question. Again, there's always a question you don't know, and the question could be, what was the question? I'm busy texting. That's okay, too. But the question is, does Tina have COPD? Your answer, please. Oh, my goodness. 85% say yes. How could you say that? Gold would come and say they would abolish you. They would ban you from medicine and respiratory therapy. They would say, you can't say that, the spirometry is normal, that just doesn't fit. No, that doesn't work. But you must have looked at my lecture. Now, we'll ask this question again at the end, but you already got the answer I would think about. But very interesting you presented it that way. Thank you very much. So again, this is the definition, and let me focus on some of the key parts of this definition. The first is persistent airflow limitation. And Gold says spirometry is required to make a diagnosis. So how could you say yes to Tina? Now, they talk about respiratory symptoms and absence of other diseases and risk factor like cigarette smoking, but they're not really part of the diagnostic criteria that Gold uses. And we do not do a service to our colleagues in primary care and who are not involved in respiratory care, because we haven't made diagnostic criteria, but it seems to me the only diagnostic criteria here is spirometry. So by this, Tina does not have COPD, different than your answer, right? So I'm not going to tell you all about COPD. You know about that. You know it's the 4th leading cause of death in the United States, has exorbitantly high medical costs. It's devastating for patients and family. It's underdiagnosed and overdiagnosed, but here we get to Tina. So is Tina overdiagnosed? People don't talk about overdiagnosis much. A patient like this comes in your office and you have the spirometry, and you don't get a good history about everything else, and you would say, well, spirometry is normal, go on your way, and I'm not going to worry about you. So let's talk about people with normal spirometry a little bit. So I'm going to talk a lot about COPD gene, which is a population of 10,000 patients. In Denver, we're the primary site. There are 20 sites around the country. I'll show you a long list of investigators. On a recent paper, we have 60 names on the paper because it's a team effort. You know, it takes a village. It takes more than a village to write articles about COPD using COPD gene these days. So this is really a cohort of smokers. We decided initially, this was not meant to be a longitudinal study. Then HLBI gave us money to establish this cohort and look at the cohort and find genetics related to why people get COPD. Why do some smokers get it and other people don't? Why do some people not get it and other people do? The flip of the question, but not usually the way we pose it. We're looking at that now. Why are some people protected against COPD who are heavy smokers? We don't know. But there may be some individual variation, obviously, between patients. So this is a cohort of smokers. We enrolled smokers whether they had COPD or not. Interesting, it allows us to see people who do and don't have COPD. And our population here is well balanced with males and females. Most traditional studies, especially in other parts of the world, have more males than females. We have pretty much equal distribution. And we specifically targeted a third of our patients to be African American. Now, we have no Hispanics because that would confound our genetics. We wouldn't be able to do that well if we had Hispanics and non-Hispanics and white and African Americans, so we chose this for scientific reasons. Now you see that 44% of the patients, over 4,000 patients, had no spirometry COPD. Interesting. And this slide, if I describe it to you, you'll understand it a little more clearly. FEV1% predicted is at the bottom. Toward the right is higher FEV1. Toward the left is lower, and you see a line at 80%. So COPD is defined by GOLD as an FEV1 below 80% of predicted. That's to the left of that vertical line. And also with airflow obstruction, FE1, FEC below 0.7, that's below the horizontal line. So the green, the blue, let's see if this works here. This area here is COPD. So GOLD 2, 3, and 4, you see down there, right here. This is people with no COPD. This is people GOLD defines as mild FEV1, FEC below 0.7, but an FEV1 of greater than 80%. And this group up here, Prism, we'll talk about that. Very interesting group. Previously, it was called restrictive. We're not calling it that. We have a different name for that. So GOLD, in its original iteration, said people who smoke, who have normal spirometry, are GOLD 0. Now, they abolished that name, so we can't really necessarily use it anymore unless we refer back to the 2005 edition of the GOLD strategy. But that meant, why did they do that if patients had normal spirometry? Why did they call them COPD? Well, originally, the GOLD document was to improve awareness of COPD and help in public health around the world, and said, well, if we target these people more, maybe the smoking cessation might help if we target that they have a problem. They wanted to intervene when the disease was not yet a health problem, and people in GOLD 0 often have cough and phlegm, and they thought that was a pre-development of COPD. People have cough and phlegm before they developed airflow limitation. So we have 2 papers about smokers without airflow limitation. One is from COPD gene, and the other is from another large NIH cohort called Spiromics. And Spiromics has about 3,500 patients. So we showed in this article published in 2015 that smokers with normal spirometry weren't necessarily normal. There were 4,388 with what we call GOLD 0, that is the smokers with no airflow limitation, and GOLD 1, mild COPD, so we compared them. And you can see most of these features are similar. Chronic bronchitis in both GOLD 0 and GOLD 1. Symptoms, SGRQ is a health status questionnaire used in COPD. Score of greater than 25 is felt to represent significant health status impacts. You can see it's abnormal in both GOLD 0 and GOLD 1. And MMRC 2 dyspnea. So this is the answer to the question, do you have trouble, do you have to stop walking at your own pace, or can you not keep up with other people? That's GOLD dyspnea grade 2 or more. Decrement in a 6-minute walk below 350 meters. Airway disease and emphysema on CT scan. Exacerbations that are severe And now severe exacerbations means you're hospitalized. Similar in GOLD 0 and GOLD 1. Why are these people treated with respiratory medications? It's not part of GOLD. Well, maybe the physicians and the patients are smarter than we are standing up here. They recognize there's a problem and they treat their patients and they stay on the therapy. Tells you their patients and physicians see a problem here. So we said, how do we put all these together? So we said each of these issues is an impairment. Patients have symptoms, they can't walk, they have a history of exacerbations, they have radiologic abnormalities. So we put these together and we said, how many people are impaired if we look at these features? And you can see any impairment. GOLD 0, 54% of patients had some kind of impairment as we define it. 6 impairment, 5 impairments, 4 impairments. So 54% had some impairment compared to GOLD 1 who had some more impairments as we look at this. But these patients think the message is they're ill. Now, why if they're ill and they have something and these are respiratory issues, why do we not call them COPD? Because they have normal spirometry, but they have something. Now, how do you define this? Do you give this group a different name? We struggle with that. The second paper was from the spirometrics cohort and showed very similar things. This made the New England Journal of Medicine, although it was published after our COPD gene article. We like to be competitive, and we're competitive with spirometrics. We submitted our paper to New England Journal too. They submitted it first, so they got in the New England Journal. We only got in JAMA Internal Medicine. And they found symptomatic ever smokers used bronchodilators, just as we found, and they used inhaled steroids as well. So it seems like there's some issue here, right? Related to smoking, even if you don't have an abnormal spirometry. Let's go to that other group here. In the top left, we call it Prism. Now think about these patients. Who are they? So let me show you their lung function. So the definition of Prism, preserved ratio, so the F1 FVC ratio is above 70%, 0.7, so that's normal. So classic, by the classic definition of airflow obstruction, they don't have it, okay? Their FEV1, however, is reduced. Their vital capacity may or may not be reduced. Previously, this was called restrictive physiology. Not so sure that's the best name. We coined this term, and others are now using it, so you may see this term more commonly in the literature, Prism, or restrictive physiology. So you'd say restrictive, they're all obese. Not necessarily. We found, actually, interestingly, that 12.4% of patients in our cohort had this kind of physiology, which was much more than expected. In fact, when we first found this, in our center, there are 20 centers in COPD gene, and we run the administrative core. We found it in our center, we talked to our executive committee, should we not include these patients in this study? Because we don't know what they are. We said, of course we have to include them. We're finding them. You need to find out about them. So the advantage of large cohorts is you have a lot of patients, you find things you don't expect, but you have the opportunity to follow that up and figure it out, as Tom Petty would. These patients had dyspnea, 6-minute walk distance wasn't good, chronic bronchitis, they had CT abnormalities. Interesting, more were females, they had more diabetes. They did have a slightly higher BMI too. We did a cluster analysis and we found 3 particular groups here. Patients who had more restrictive kind of physiology with a higher FEV1 FVC and the least emphysema and gas trapping on CT scan. We found a group that seemed to be more COPD-like. They had the lowest FEV1 and FVC ratio, and they had more emphysema and CT scan abnormalities, and the lowest BMI. Then we found people who we called metabolic because they had a lot of diabetes. So we've done some genetic analyses as well in this group to try to figure out what they are, but there's different clusters, so we're still working on these. Well, what about chronic bronchitis? Okay, we'll shift gears here. Cough and phlegm. Well, you know, it used to be, I have to tell you, 10 years ago, I asked my patients about cough and phlegm, but you know, I never wrote it as a problem because you can't do anything about it, right? They smoke, you should tell them to not smoke. But COPD was on my diagnosis list, my problem list, my EMR. Chronic bronchitis I didn't put on the list so much. Then roflumilast came out, which is targeted to patients with chronic bronchitis, reduced exacerbations. I said, whoops, maybe I should put it on my problem list so I know about it. And then we started investigating it, and now it's the first question I ask every patient that comes in. Do you have cough and phlegm? So in our first 2,500 COPD gene subjects, we had 1,000 that had stage 2 or more COPD. They had chronic bronchitis by this definition. Now, this definition is complicated. I don't know how you ask about chronic bronchitis, but I teach my medical students and residents and fellows all the time, and they don't know how to ask the question. Because if you ask the question, do you have smoker's cough, you get a lot more responses than if you ask these, right? So you need to ask the question very carefully. And if you use the ATS questionnaire that dates back eons, if you will, by Ben Ferris in the 70s, there's 6 questions to ask about whether they have cough and phlegm, both of them, for this period of time. So it's not easy to figure this out and ask patients about it. We found some simpler questions that I won't tell you about, but there's a simpler way to ask it. So in our first 1,000 patients with COPD, we had about 1/3 that had chronic bronchitis and about 2/3 that didn't. And we said, well, what's the difference? Does chronic bronchitis make a difference? Did Dr. Petty, was he right in identifying chronic bronchitis as a problem? You can see their dyspnea score was about 1 point higher. They were more short of breath. Their SGRQ was about 13 points higher. 4-point difference is a clinical significant difference in SGRQ. This is 13 points different. They had major impacts on their health status. And when you talk about exacerbations, chronic bronchitis in the blue, twice the rate of exacerbations per year than people without chronic bronchitis. And more hospitalizations. 26% of the patients with chronic bronchitis had a hospitalization for exacerbation, only 20% those without. Now that's people that have COPD. What about smokers without COPD who have chronic bronchitis? Interestingly, a lot worse health status. They were not doing as well, even if they didn't have airflow obstruction and didn't have COPD. So chronic bronchitis, going back to Dr. Petty, he was right. So, next question. Do individuals with a history of cigarette smoking and either normal spirometry or Prism spirometry have healthy lungs? So the answers are possibly either yes, they do, or no, they don't, and I'd like to see your responses. I convinced you. Well, thank you. So I do this, there's different ways to ask the question, different reasons. So an educator would tell you, my wife would say, well, you need to make sure people understand what you're saying. I would say, well, how do they interpret what I'm saying? Do they believe what I'm saying? Am I right or not? Well, I don't know, but this is, I tell you, this is one perspective. I'm going a certain direction here, and I hope you follow me, but you at the end could say I'm crazy, but it's okay. I actually don't have that question. Maybe we should put that in. Am I crazy? So we wanted to call our article The Myth of the Healthy Smoker. But the journal editors would not allow that, so we're not calling it that, but I like to use that term. That's people without airflow obstruction who have symptoms, and the problems are we don't know much about them. Do they progress? What's their outcomes? How should they be treated? Well, we don't know those answers. So we took the information about smokers who didn't have COPD and had Prism and said, we need to think about something else. Let's do an integrated, multifaceted, multi-component approach and use all 4 of the cardinal features of COPD. What are the cardinal features of COPD? Environmental exposure. Now, all our patients were cigarette smokers, so we didn't have any without cigarette smoking. Clinical symptoms, we used dyspnea and chronic bronchitis, very impactful for our patients. Chest CT imaging, we used emphysema and also gas trapping and thick airways, and spirometry. And we said of putting these together, multifaceted, a diamond is multifaceted, that better defines disease and identifies important outcomes like spirometric progression and mortality. So this is an article which is in press. It's not online as of yesterday, but it should be online soon. And I think this issue of the Journal of the COPD Foundation, this is the medical journal for the COPD Foundation. I'm one of the editors. This article will be out by the middle of the month in a special edition with some other articles from COPD Gene. So this is called Redefining COPD, and we're using the term COPD Gene 2019 to define this definition. It's a free subscription, so if you go online to the journal, you can sign up. All the articles are free, it's open access, you don't have to pay for it, you don't have to go through your institution, so I encourage you to sign up, particularly look at this article, but other articles that come out as they come out. So, hypothesis, was our hypothesis correct or not? Well, here's our diamond, okay? So let me show you exactly what we did. We used these 4 criteria. So for exposure, everybody in COPD Gene had to have at least 10 pack years of cigarette smoking. Now the average pack years was about 35, so these were not light smokers. So everybody had exposure. Some people had symptoms, and the 2 symptoms, again, are shortness of breath. We define that as dyspnea grade 2 MMRC or worse, or chronic bronchitis using those 6 ATS questions. So that defines people that had symptoms. You can see that in the purple small diamond, okay? Then CT structural imaging disease you see in the blue triangle, and structural disease we defined as, and we quantitate our CT scan, so this is not something everybody necessarily can do, but we quantified them by computer algorithms, emphysema greater than 5%, or gas trapping, which we think represents small airway disease. On exhalation, you still have gas trapping greater than 15%. And the third one on the bottom there, because we really want it on the bottom, we specifically put it on the bottom, is spirometry, either with classic airflow limitation with an FEV1 FVC less than 0.7, or Prism, okay? So those are our 4 quadrants or facets that we put together. And I think this is the most important slide I have to show you to carry away as you think about this concept. You know, there's more to COPD than spirometry, and these are the issues you need to think about. So we said, forget about gold. There's the diamond. Diamonds are a girl's best friend, and we have a diamond description here. So remember the diamond on the right, and remember one on the left, and you remember a new diagnosis, a new way to define COPD if you think about diamonds. I hope you carry that away. So these next slides are a little more complicated. So we found different subgroups. If you put together those 4 features, you can have some patients who just have cigarette smoking. Cigarette smoking plus CT scans is category B. C is exposure plus symptoms. D is exposure plus spirometry abnormalities. You can see we can add all these different combinations together. So we define possible COPD as patients that had 2 of those features. We said probable COPD is people that have 3 features. If you have all 4, even if you have Prism spirometry, this is not necessarily classic airflow obstruction, you have definite COPD. Now, we thought about coming up with some different name. What do you call this? Call this, I don't know, diamond COPD. We didn't think that was good for the public consumption, but I think it's good to describe it. But we couldn't think of a name, so we called it COPD Gene 2019. Now, there's some other reasoning behind why we call possible, probable, and definite here. And I'll show you what's behind this slide, which is even more important. Why is this so impactful? Because if you look at the odds ratio in the 3rd column there of an FEV1 change of more than 50 mLs per year, okay, 350, but it's more than 50 mLs per year, or the hazard ratio in the 4th column of all-cause mortality, you can see as you go down the columns, there, after you get past A, there's significant odds ratio of spirometry getting worse and mortality in these groups. And you can see as you go from possible to probable to definite, the odds ratio goes up even higher. If you look at H, the bottom row, 2.82, the odds ratio of having FEV1 decline of more than 50 mLs per year. If you look at the hazard ratio for mortality from all cause, 5 times the mortality. So I think it's reasonable to say those patients have definitely something, whatever you call it. Fortunately, we have to call it COPD, but if you think of a better name, let me know. Okay, so that's why we figured out those classes. And if you summarize that into possible, probable, and definite, possible COPD, you see the odds ratio is 1.2. It's really modest, okay? If you look at probable, it's definite that they have FEV1 change over time and they have mortality. Look at definite, absolutely, okay? So that's what's behind this. You know, we have not said everybody has COPD. They probably, possibly. And we obviously need further investigation to refine this more. Again, look at the clinical significance in other populations, and more work needs to be done nationally and internationally. So if we think about Tina, where is Tina? Well, she has cigarette smoking. She's in category E. She has symptoms, chronic bronchitis. CT, she had emphysema that somebody found on her CT scan, so she's in probable COPD. If you look at group E here, 1.74 odds ratio, almost twice the odds ratio of developing decline in FEV1, that's very significant. If you look at E across, hazard ratio almost twice the mortality, so definitely needs to be followed up much differently than a patient who doesn't have COPD and you're not worried about their lung problems. So I go back to this integrated approach, which I think based on what we're showing you, does better define disease than by spirometry only. It identifies spirometric progression and mortality. So that's the takeaway message. So I also presented, I didn't think I had time to present in this session. I presented in the same issue of the Journal of COPD Foundation a perspective that's longer than the editors wanted, but it's there anyway. And I presented an algorithm how to implement COPD gene in clinical practice. It obviously suggests further research needs as well. If we don't identify these patients, we can't study them. We can't figure out how to treat them. We can't figure out what their problems are long-term, how to prevent them, how to prevent mortality. So defining them is only the first step. And defining them means, in essence, you ask everybody about smoking history. Now, we do that all the time, right? So that's commonplace. But then we need to ask all smokers about symptoms. And again, chronic bronchitis being hard to ask, we need to ask it specifically so we know we get the most appropriate answer that defines chronic bronchitis. And we need to ask them about dyspnea. How to ask them about shortness of breath? I think it's very hard. If you ask a patient, "You use short of breath?" Say, "No." Asked my COPD patient once, "You use short of breath?" He had stage 4 spirometry COPD. His F1 was 20%. He couldn't walk across the room. He was sitting in their chair. He said, "No." I said, "You're not short of breath." Let me think about that. What did I do wrong? When a patient answers a question that I think doesn't give me the answer that I think is probably appropriate, it's my problem, okay? My problem was he interpreted the question as, "You're short of breath now sitting in the chair," and he wasn't. So I didn't ask the question right. So I think the way to ask the question about shortness of breath based on COPD gene 2019 is MRC grade 2. Do you have to stop walking at your own pace or you walk slower than people of your own age? If they answer yes to that question, they're short of breath. So let me go back to Tina. Let me ask you a question again. It's hard to get more answers than one of the columns we had before, but we can try. So does Tina have COPD? Now, remember, she has exposure, a smoking history. She has chronic bronchitis when she's well. She has a structural abnormality in terms of emphysema on her CT scan. She's got Prism spirometry. So does she have COPD? Yes, no, or I'm not sure is fine. Your answers, please. Okay, well, it's a little higher than before. Okay, so either I did a good job, either I'm a good salesman, which could be too. I don't want to ask why you're answering it this way, but that's interesting. So we'll go back to the gold definition of COPD now, right? The gold definition, where do you stand? Is it definitely good? Is it terrible? But should it be expanded? If you say it definitely should be expanded, to me that's a modern answer because you're listening to most recent research. If you say no, the gold definition should not be expanded, well, you know, that you're in the past, I think, and you're not looking forward to the future. And that's why I put back to the future. So let's see what your answers are. Not that I gave you what I think your answer should be. Okay, that's perfectly appropriate, okay? Because I think people say that no, the definition should not be changed. There's a lot of history behind that definition. We know a lot about those patients. We know tons about them. You know, if you think about the original gold and the original ATS is where the spirometry grade came from. This is a paper in 1995, the ATS standards for COPD that I was part of the writing committee. They used the classification of spirometry grading that we use now in terms of severity. Without somebody speculating that those are the spirometry grades and speculating that A, B, C, and D were important, that would not spur research. So I see gold really historically as being a leader in research for people to say, yes, the gold strategy is correct or not correct in different areas. I think we're doing the same thing here. We're saying there needs to be a lot more research, but you can't neglect the fact that you need to study and evaluate these patients more. So that's because you got the right answer. I was going to skip it if you didn't. So I'd like to thank all the COPD gene investigators, and you can see multiple here. This was our initial list, and people have gone and come onto the list, but you can see how many people it takes with 20 sites around the country, and this is funded by NIH. Now, I know that Ted Koppel yesterday, I call him Dr. Koppel. I know that Dr. Koppel, he's got an honorary MD degree, at least as far as I'm considering. I think Tom's shaking his head yes. Dr. Koppel said there's not enough money spent on COPD research, but you know, there are studies that are very, very impactful, like COPD gene. We need to fund more studies like that to find out more about COPD. You can see the impact of that study. Do you know we have 300 published manuscripts in a little over 10 years? We're now seeing patients for a 10-year follow-up. So it's been great for, I think, the world in COPD. We've redefined what CAT scans mean in COPD. So what I would suggest our expanded definition should be patient-centric. Think about symptoms. That's what our patients complain about. Think about CT scans. Now, everybody's going to say, no, I can't get a CT scan. Insurance is not going to pay for it. Well, they pay for lung cancer screening CT scans. So you have a lot of CT scans on your patients that you can use to identify emphysema and airway abnormalities already. So they are done commonly. Airflow obstruction, we all do spirometry, and these people have poor outcomes. So where would Dr. Petty be with what we say today? So I think as he's smiling here, having caught this big fish, he would have endorsed the progress we're making in the diagnosis of COPD. Now, there's something I think he would not necessarily be proud of. Well, that's an oxygen bar, and I found this on a trip to Las Vegas to give a talk. And I don't know if you can see the names of the oxygen flavors: sex on the beach, fuzzy navel. So I think, you know, we'll talk about vaping problems. We may have respiratory problems related to breathing oxygen in an oxygen bar, so Dr. Petty would not be very proud of this. And I want to follow up Dr. Koppel's remarks as well. So this is called grassroots COPD. So at the ATS meeting, I gave out, I don't know, several hundred flash drives, and they weighed 35 pounds. How do I know that? Well, I had to take the suitcase. They needed a separate suitcase. I had to take the suitcase on the airplane, and I had to make sure it wasn't more than 50 pounds. So I handed these out at the ATS meeting. So the National Heart, Lung, and Blood Institute had a town hall meeting a couple years ago, and they developed the COPD National Action Plan. which said there needs to be more involvement in COPD and more research in COPD. And this was the input from patients, providers, insurance companies, pharma too, I think, was there. So they have a plan. Problem is they haven't operationalized that plan. COPD research, and particularly pulmonary rehab research, is very underfunded. So our goal is to get people to write to their federal legislators, and we want your legislators to write 2 letters. One letter to NIH saying operationalize the COPD action plan. It has nothing to do with more money, it's reallocate the money you currently have. And the second is to send another letter to Medicare and say, get involved here, okay? Get involved in a project that we have pending before the NIH. The project is called Propel. Propel patients forward. This is pulmonary rehab after a hospitalization with the goals of seeing whether it improves survival as well as reducing readmissions. Very impactful. It will change practice. It will change payment. The study was scientifically approved by the NIH Council, which is the last step in getting approval, has not been funded because the NIH says it doesn't have enough money, despite the fact they told us to submit a project this big, you need to get prior approval and you need to send a budget. We sent a budget, they said fine, our budget came in under what they approved, and it's still not funded. It's waiting prioritization next year whenever they get the next federal budget. So I agree with Dr. Koppel that we need to take things into our own hands and write to our legislators, and if you go to the site, it'll provide a sample of some letters to send to them. So Dr. Petty also would have been proud of patients. These are patients using oxygen. My favorite is the woman in the middle, the vertical one, who's decorated her oxygen tank. Transtracheal oxygen in one of the patients. Patient in the top left is one of our patients who puts his oxygen tank on his bicycle and still rides his bicycle. So I think it's not just we that innovate, we look to our patients to help us innovate as well. Thank you very much.